I promised you to show you ear infections in high def, so we might as well get that out of the way right off the bat. This is the slide that I graciously stole from Neil Herendeen and the folks at University of Rochester, where they have an excellent school-based telemedicine setup. They are connecting 30 sites with approximately 10 pediatric offices through the city to do acute care, and they are in primary care, elementary schools and Head Start centers, and now expanding to neighborhood centers with a mobile unit. And as you're looking for evidence to support your use of school-based telemedicine, the folks at University of Rochester have really put together the best of the research that I've seen to date. Excellent health expenditure and health services research coming from Neil Herendeen and Ken McConaughey at Rochester. But I live here, kind of where this arrow is, in Mitchell County, North Carolina. We're on the Western Mountains, and we are a very remote area. Between our two counties, Yancey County here and Mitchell County here, this is Tennessee, here to the north. Asheville would be sort of down here. In our two counties, right now we have 4 miles of 2-lane highway. The elevation varies in our counties from about 2,200 feet at the sort of southeastern side to over 6,000 feet up here on the northern edge. And also the tallest peak east of the Mississippi River, Mount Mitchell, is right here, and Mount Mitchell is 6,600 feet. We're small communities. There are about 38,000 year-round residents between the two counties, and actually our populations have been dropping a little bit. Between the two counties, there are currently 17 public schools, and there are 4 active school-based health centers. In Yancey County, they're located at the 2 middle schools, Cane River Middle School and East Yancey Middle School. And then in Mitchell County, I see patients at the Tipton Hill Elementary School and the Beulah Dean Elementary School, both of which have less than 100 kids. And when I came to Mitchell County, I was really interested in how we could begin to provide school-based health services, which I sort of had bought into as a Teach for America core member back in the mid-90s as an ideal way to provide health care to kids and bring those services to rural areas. And when I was at University of Rochester, I had the opportunity to spend some time with Neil Herendeen and the folks there with the Healthy Access program, and got excited about this idea of school-based telemedicine. So the other pieces of information to know about the two counties are they are both HPSA, or health professional shortage areas for physicians. They are also mental health professional shortage areas and dental health professional shortage areas. We have one hospital in the two counties. It's Blue Ridge Regional Hospital. I see patients there, deliver babies there, and it has 48 beds. It is not a critical access hospital, though. And one of the great things that's happened in North Carolina is that we have the school systems have all put in fiber optic networks, and through the generosity of the two school districts, we've been able to use their fiber optic networks as the backbone of our clinical infrastructure, or our telemedicine infrastructure. So, as most folks know, the 6-year-old who has an earache at school, when there's not a school nurse, runs into a problem. The school typically will call the parent, and in our situation, those parents often work 30 or 40 miles away down the mountain at the Baxter plant in Marion, North Carolina. And so the parent needs to drive to school, then hope that they can get an appointment in one of the doctor's offices in the area. That's a challenge because there aren't enough doctors for the people who need to be seen. And so often these kids will end up in the emergency room. If it is an infection, they may get a prescription and need to drive to the pharmacy and then drive home. So not counting time sitting in the doctor's office, etc., parents are spending an hour and a half probably behind the wheel to get to the to school. And in our emergency room, we did run some initial data to try to take a look at, are we meeting, is there really a need? And I think that as you're thinking about a school-based telemedicine network, you got to look at, is there an access need? And so what we have done, we took a look at a 3-month period from January through March of emergency room visits from 8 a.m. to 6 p.m. for 5 to 18-year-olds. And we found that 75% of those visits could have been better cared for in a school-based health center or a primary care medical home, but because of access issues and insurance issues, the kids were not able to be seen. With the telemedicine network, we eliminated a lot of the driving and a lot of the burden on the parents. Most of the folks up here work jobs that are on assembly lines or out as loggers, and so getting away to go and pick up their kid, take them to the doctor, directly impacts their paycheck and their potential to stay on the job if they have a kid with a chronic illness like asthma. So we really try to get rid of the parent needing to drive as much. In the case of an earache, a kid could actually probably take the bus home at the end of the day if they're relatively healthy, and the parent could avoid that trip to school and hoping to get in to see the physician. Just stop by the pharmacy where we've e-prescribed the medication, and then meet their student at home, and really take a burden off the parents. So that's sort of the model we were working with, and I think that one of the unique things about our project is that, to the best of my knowledge, we're the first truly community-based program. There are some great programs out there, but they tend to be affiliated with large tertiary care centers, children's hospitals, and also large federally qualified health centers. We haven't had that luxury, for better and for worse. So when I started to develop this, it really was about 4 years ago, and I started out taking a look at some existing models. The first was the University of Rochester model that I was most familiar with, and then talked to the folks at Akron Children's Hospital, where they linked to two schools in eastern Ohio, where they linked those kids back to their primary care physicians' offices, and then also talked with Ryan Spalding and the folks out at Kansas University Medical Center, where they were doing some great rural school-based telemedicine, linking back to the pediatric residency clinic for acute care. So trying to think about ways that we could begin modeling this and replicating it and changing it to be community-based took some time. And initially I was very fortunate in 2007 to become a Jim Bernstein Community Health Leadership Fellow, which is a state-supported primary care fellowship here in North Carolina. Actually looking at access to care, looking at ways to improve care, more than looking at ways to get doctors into rural areas. And in my first year, I spent the time researching. I spent the time doing some learning, going out to UC Davis, and of course I met the folks from Arkansas, which was a huge benefit. And in our next year of operation, we were able to start getting some planning funds, and these were critical because the planning funds really allowed us to take the time to develop a model, to develop a process. So the initial planning really consisted of research first, and going out to UC Davis, where they have a great 3-day telemedicine course, sort of a nuts and bolts primer, everything from how do you do an interview to what's the technology about. That gave me a real ability, I felt, to go and talk to folks at the American Telemedicine Association, and I can kind of talk the language of IT networks enough to get myself in trouble. And I know the clinical care pretty well. I then, after a year, in May of 2008, invited the school districts, invited the parents together to do a community-wide presentation. And we had about 75 people attend this Steve North's got another crazy wild idea session at the school system. And we talked about the opportunities to do school-based telemedicine and what that could mean. I'm fortunate that at East Tennessee State University, just over the mountains in Johnson City, Jody Palaha is a psychologist there, and Jody has an extensive history in both Nebraska and Tennessee of doing school-based telepsychology. And so early on, we were able to use some low-end units called the in-person by Creative to do some fairly low-tech telepsychology at one of our rural schools. After launching the plan, it really became essential to build relationships, and one of those with a local 501c3 focused on child health and development, and the Grandchildren's Health Services of the Tow River, a fairly awkward name for a great organization. But that gave us the protection of a 501c3 and the opportunity to get grants and do some fundraising. So from there, we formed an advisory board consisting of school system members, local healthcare providers, and we were able to hire a staff member through the money from Kate B. Reynolds and the Community Foundation of Western North Carolina, and applied for a catch grant through the American Academy of Pediatrics in conjunction with a local pediatrician. What that allowed us to do was to really take a year and do some great research and project development. And that included sort of developing our image and what we were going to be. We did create a little nice logo. One of my close friends did that. And we also began to have a social media presence on Facebook. The first thing we did was we conducted 12 listening sessions. And we went out with some sort of standardized questions and began talking to school nurses and local healthcare providers. We talked to a group of at-risk students, some who had already dropped out and were working on their GED, others who were on the verge of it, several groups of parents, teachers. School nurses are a critical partner in this, in building this, because if you don't have school nurses investing and seeing the benefits of school-based healthcare in general, you could really run into some resistance. What we heard from the healthcare providers was some concern about job security on the part of the school nurses. Well, you're just going to replace me. And also physicians being concerned about patients. And it's at that point where you really need to be able to come with some data and take a look at what we looked at were Medicaid well child checks and what percentage of kids were getting the recommended well child checks in the county. And so if you can show, which we did, that between the ages of 5 and 18, less than half of those children were getting the recommended preventive care visits, right there you have a case that while these are all great physicians, we don't have the capacity to provide all the healthcare services that a kid needs to grow and mature. And that was especially seen in adolescent patients, which is an issue across the country. The at-risk kids talked about the benefit or the need for for confidentiality. Teachers saw a great need. They see kids coming to school sick every day. And then finally, there were the parents. They were interested. A lot of them showed an interest in getting sports physicals, which is a really different topic that I don't want to brush on today. My opposition to the sports physical, but and the herd in the gymnasium. But we really worked with our school nurses as the first folks to try to get on board. And one of the resources that we used was a sort of a flow sheet or a chart from the National Assembly on School-Based Healthcare and the National Association of School Nurses that they had developed together. And it talks about sort of the difference between school-based healthcare and school nurses and how these folks can overlap. School-based health centers really focus on individual health. while school nurses are almost a public health focus, sort of system-wide, working on IEPs, working on vaccinations, and making plans to manage chronic illnesses, tube feedings, catheterizations in the school setting, and really tried to lay out how we could work together to find mutual benefit. The biggest piece of our needs assessment was to do a family survey, and we sent home, using the great, highly validated backpack method of distribution, a survey to all 4,328 kids in the 2 districts. And we actually got a fairly great response rate. We got 31% response rate, which for basically a mailed survey is very good. So we had just over 1,300 respondents. Good confidence, 95% confidence intervals, or confidence level of 95% was providing a confidence interval of 2 to 3%. And what we really were looking at was that, parents' perception of their children's healthcare needs and access to health services, the impact of their child's health on their own work attendance, and also on the kids' school attendance, and also the parents' interest in and also likelihood to use a rural, community-based, school-based telemedicine network. So I'm going to sort of summarize our findings through a couple of slides. The first is taking a look at what parents desired as far as health services at school. And you can see, lots want acute injuries to be addressed. One of the things that we saw that was quite interesting, I feel, is this strong interest in counseling for depression, drug abuse, and family problems. Because one of the superintendents had told us that his kids really didn't need any access to mental health services. And our parent survey said, wait a minute, a third of the parents out there feel that that should be available at school, and right now we aren't able to provide it. We then asked a question: would you consider letting your child use school-based telemedicine services? 52% of parents, just over 52%, I'm sorry, did my math wrong. It's 58.1% said yes or they probably would use the services, while less than 10% said probably not or no. And we did get some interesting responses as to why they would not let their children use it. Fear of us passing out condoms and contraception, and abortions were mentioned. I think Michelle Bachman had visited here earlier in the year, and then also that their pediatrician was the only physician who could really take care of their child well. We then went on and asked those folks who said in the middle, I don't know, well, what is it you'd consider letting your child use telemedicine if? And these questions, the responses, really focused on more education, more parent information. They want to know more. They want to know if they can come and be involved in the visit. What would be done if there was a true emergency? And do they know and do they have confidence in the healthcare providers? There were some mentions of concerns about crying wolf and that kids would overutilize the service. So from this, we did a bivariate analysis, taking the 58% of folks who said they would use or probably would use, and comparing them to those folks that were not sure, probably would not use, or would definitely not use. And we looked at, did insurance type matter? And we found that when we looked at support for telemedicine, parents who had public insurance, so Medicaid or Health Choice, were much more likely to be supportive of the use of telemedicine than those who had private insurance. And that's kind of an interesting viewpoint. Do folks in our community, which has the bulk of our schools are Title I schools, so indicating a high Medicaid rate, do folks with public insurance really have a harder time accessing health care than those with private insurance? We then asked, well, what about missing school versus telemedicine support? There was no statistical difference here. And this is in the context of parents responding in another question where 73% reported their child had missed school for a medical appointment, and almost 60% believed their child's attendance at school would improve with access to health care at school. So even if your kid misses school, you're saying, well, not sure if it impacts my likelihood to use telemedicine, but we see that there is a high rate of kids missing school currently. Thinking about that, one of the insights was, right now, it's natural. It's the sort of status quo that if kids are sick and need to go to the doctor, they will miss school. Most parents don't know something different. And when we looked at, obviously, if parents felt that telemedicine, access to school-based healthcare would improve attendance, they were more likely to support the use of a telemedicine network. Parents also, in sort of a corollary to the missing school, parents who missed work were not more likely to support the use of a telemedicine network, although over half of parents said that they had missed work to take their kids to the doctor at one point or another. We then looked at grade level support, and our initial thoughts were that parents of K through 5 kids were going to be, or grades 1 through 6 kids, were going to be much more likely to want their kids to be seen. You know, we all think of the snot-nosed second grader who's wiping his mucus all over the place. I have one who lives in my house. And what we found instead was that it was the parents of the middle school and high school students who were more supportive. Thinking about that more, talking with people as we sort of reviewed our findings, we kind of thought that, well, high school students, middle school students, there's a whole lot more going on in their day. And so if they can get a healthcare visit taken care of without missing soccer practice or tutoring or missing the bus ride home to take care of younger siblings, it would be great for the family as a whole. With that information, we began looking at the feasibility of operating this network, because financial sustainability is something that, if we're going to replicate what large universities have been doing, not every school district or every small clinic is going to be able to get HRSA funding to do what the University of Rochester has done. And so we looked at 3 models in our feasibility study and looked at the number of kids we'd need to see in each model. The first was a model where every school was connected to every primary care office in the area, so that, like in the Rochester model, students could see their own primary care provider. And for that to work, we would need to be seeing each child enrolled in the network 12 times per year, which is a whole lot. We looked at a second model where we used a couple of select primary care sites and tried to reduce the numbers down, and still serving all 17 schools, we'd need to see every kid 6 times a year with that. So a significant reduction. But by taking the network and having a central hub with one nurse practitioner and being able to get both the school-based, both the reimbursement for the visit and, in addition, get the site fee, North Carolina Medicaid and North Carolina Blue Cross Blue Shield do reimburse $22 per visit for the use of telehealth services. We found that we could get down to about 2.5 visits per enrolled student per year to break even. These numbers are a little bit old. We do need to revise them, but that's a much more feasible number and reflects better what happens on a national level with school-based health centers. So we took all this information and began to think about a program. We looked at our survey results, and having this survey has been critical for grants, but also helped us to really think about the key components that we needed to use and that anyone else who's developing this should really be thinking about. One of the things that came out of our focus groups, and also looking at my personal biases as a provider and insurance reimbursement, was that we wanted this to be a real-time network. Most insurance companies and Medicaid do not reimburse for primary care store and forward visits. So the ear infection, the strep throat, the rash, the follow-up asthma, follow-up ADHD can't be done in a recorded manner. And we really need that insurance reimbursement to stay, to become profitable and become financially independent. I also feel that it's much harder to do prevention and health education tailored to the needs of a specific student if you're not doing it in real time and not able to follow up on the questions. We also wanted to be real clear about how do we involve our school nurses and their concerns. So we involved them in the process of designing this program. We are meeting with our school nurses probably once every 3 months on average right now, and involving them in policy and workflow decisions. Connections to local physicians have been a challenge. We've had one local physician who's been very, very vocal about her opposition, and she talks about why can't she just go up the half mile to the school, a half mile from her office, and see patients. And in the 2 years that she's been providing this vocal opposition, she's never gone to the school to see a patient. So there is sort of a mixed message coming from this doctor, and that's a challenge. But getting that connection to local MDs, how are you going to get them the information in an effective manner? How are you going to get the work in this concept of a primary care medical home that's being promoted? How does a school-based health center enhance their ability to provide that and or serve as the primary care medical home is something that needs to be considered. What about state credentialing? Are there regulations within your own state? In the state of North Carolina, we needed to look at we're looking at the credentialing process because Medicaid, students enrolled in Medicaid have a designated primary care medical home or a designated provider. School-based health centers that have gone through the state credentialing process are allowed to bill directly to Medicaid for these services without getting a prior authorization through what's called Carolina Access to see the kid. And then building partnerships. Our partnership with ETSU, East Tennessee State, has been essential at selling this and showing the advantages to the local school districts. And as we think about how it's going to operate and how we are operating, taking that partnership into account. So that's kind of an overview of the work we did before actually buying some equipment. And we're going to come back to the grant funding in just a little bit because I know that's an essential part. But we're starting small. And right now we have a three-site pilot network located at 2 middle schools in Yancey County and 1 elementary school. 2 middle schools in Mitchell County and an elementary school in Yancey County. And part of this is because of how our funding has been segmented. And we're really very well poised to grow based upon utilization right now. But it's also letting us figure out all the bugs. How do we get our EHR to work in 2 sites simultaneously? How do we communicate with the primary care physicians and build those relationships so that they feel comfortable referring to us for follow-up care? And also, how do we measure success? What are the outcome measures that we're going to use? So our pilot network right now consists of providing both acute and chronic care, providing mental health services in conjunction with East Tennessee State, doing health education as appropriate, and also working with Brenner Children's Hospital at Wake Forest. We're strongly looking at doing some obesity prevention work with them. They are already providing that as a telemedicine service to a Boys and Girls Club, and right now they're looking for the funding to partner with us. So that's been a great relationship to start building. So how do you pay for this stuff is one of the big questions. And we've been real fortunate. We began in 2009 by getting a local foundation to give us $40,000. And that was for equipment only. That $40,000 became critical to matching with the Appalachian Regional Commission in a 70-30 match. So we provided 30% of the funding, they provided 70%. And so we were able to get about $90,000 from Appalachian Regional Commission. So those 2 top funders provided us with the money for our pilot network. We then took this $130,000 and matched it 2-to-1 with the USDA Rural Utility Service grant. And so we were just awarded that grant earlier this year, and we now have money to go to 11 schools total over the next 18 to 24 months. And finally, in the last week, maybe some other folks out there on the call also received some HRSA funding. We received $54,000 for HRSA to go to the 2 school-based health centers in Mitchell County, and then another $145,000 from HRSA to do some work at a new school-based health center and also connect the final 3 schools. So we right now actually are in a little bit of trouble where we have a whole lot of equipment money. We have some operational funds, but we're kind of getting ahead of ourselves. We don't know how well everything works, but people like our idea enough that they want to buy in. We then have been able to get some good operational support as well. And one of the things that I found is getting that first grant is really the hardest part. And so if you can have someone buy in and say, wow, you've got a good idea, which Kate B. Reynolds has been a tremendous asset for us, providing that initial funding, and seeing them support our project has made other foundations, other organizations more likely to give us support. And so we've received 2 large operational funds grants, one from the Blue Cross Blue Shield Foundation of North Carolina. I'm sorry I said that wrong if they're on the call. And that's been real essential to cover our startup costs. Our feasibility study was critical to get these grants because we were able to say, hey, this has the potential to work. And then a second grant covering partial operational costs for 2 years from the Kate B. Reynolds Charitable Trust out of Winston-Salem. And one of the things I'm learning is that if you're not hitting your targets because it's taking longer to implement a program than you anticipated, be honest with your funders. They are, at least in the case of foundations, they have been willing, and trusts, they've been willing to extend our grant. You're not spending your money, but you're also not missing your targets yet. Go ahead and take another 6 months. That's okay with us. We want to see you reach these goals. Please don't come back to us for more money saying you gave us $150 million and we only got the needs assessment done. But if you're still working towards those goals, it's great. As I think about this and what we've done over the last 3 or 4 years, it's been tough to do. I'm doing this part-time, and most of it is uncompensated. So I still see patients 4 days a week in my office, and I've been very fortunate to have a half-time program manager for the last 2 years, and we are now moving up to a full-time program manager. You really need a full-time person who can take ownership of this with some creativity and some excitement to get involved. We now have an IT person partially on staff part-time, and that's been a great benefit. And we've been using a nurse practitioner as a consultant right now to help us develop policies and procedures and really think through things and interface with the school nurses. She is a woman who's been in the community her entire life and has great respect from community members. Everybody knows Eloise and Eloise's family. So that's been a real benefit for us as well. We'll expand our staffing based upon needs and utilization, and also based upon our reimbursement. Here's our implementation plan. Right now, we're going to be at 3 sites in our pilot network, and hopefully in earlier in 2012 than what's listed here, we'll expand to 7 sites total. We also are building a new school-based health center at the high school in Mitchell County that will house the telemedicine network, a combination urgent care school-based health center, and also some healthcare teaching classrooms. That's really another project, but we've received just over $250,000 from the tobacco money in North Carolina, tobacco settlement money to get that project going. I also find myself holding back and not applying for some grants, and that's hard for me to do. We didn't apply for the recent dental grant. MCHB had a big dental grant out for primary care dental services. I think we would have been a great fit, but we don't have the capacity right now to manage another large grant. And that's really important to keep in mind. You've got to get the operational stuff in line before you put the cameras in place. Putting the cameras in the schools is really the easiest part of this whole thing. We've had some challenges, and contrary to what Homer says, I definitely think it's worth doing if it's hard. We've had some legal issues. The school systems really have, well, one school system has really wanted to take a fine-tooth comb over the policy and procedure manual in a way that the other school system has not. And I think that's due to some internal issues that they have. And so that's delayed our getting up to full speed in one of the counties. There's this whole controversy around HIPAA and FERPA and school-based health care. There's some good articles out there to read about that. And you can really get the school and the school-based health center to talk to each other easily by having parents sign a global consent at the beginning of the year saying, I want these two organizations to work together for what's best for my kid. Please keep me informed of what you're talking about, but please feel free to talk. The electronic health record has been a little bit of a challenge. We have been working with mission hospitals out of Asheville who've been very generous. They've given us free access to an electronic health record for 9 months. But getting it set up has been a challenge because Cerner has not had any direct cash from Mission for this part of the project. And then finally, staffing. Finding good people in rural communities can be tough. Successes, we're getting a lot of interest from our community. We're also getting a lot of interest from other places. We have new people approaching us now to apply for new grants. And we did get the free electronic health record. One of the things you need to do as you sell this is look at other ways you can benefit the school district through the technology. Telespeech pathology, Michael Campbell out of the University of North Carolina, Greensboro, has a great telespeech pathology program, and we're going to work with the school districts and exceptional ed to replicate that out here. We're enhancing the IT backbone. We're putting some significant dollars in hardware onto the school district's backbone, allowing for video conferencing. And finally, we're improving care to get kids to stay in school more. Outcomes measures that we're looking at, and I am kind of behind schedule here, and I apologize, so I'm trying to go quickly. We want to look at the relationship between access and utilization of school-based health centers on attendance and annual yearly progress, on coordination of care for the school districts and also for primary care physicians, satisfaction. So thinking about things like other health impairment kids, health HEPs and IEPs. We want to look at satisfaction measures from both students and parents, potential cost savings of using this versus sending kids to the emergency department, and obviously the health outcomes, utilization of preventive care visits, and the long-term financial viability. Great resources. I'm going to work with Adam and the folks at Learntelehealth.org to set up a community online. But their setup, Learntelehealth.org, is great. Some great information there. The National Assembly on School-Based Health Center really has great operational information. And finally, the American Telemedicine Association has some very good technical information and is a good policy arm. So this is my contact information for your comments and critiques. Please feel free to reach out to me, and I'll try to answer your questions or else send you in the right direction. And that's my PowerPoint. And are there questions out there? And what can we do to answer them?
Anybody want to take the first question? I'll remind the viewers on the live streaming, you can click the button that says click here to ask a live question. You could kind of text in a question on the live streaming, so please feel free to do that. But I'll send the first question out for anyone who's out in the audience.
We got one online.
Okay, we actually have an online question, Matt.
Okay, regarding the special equipment on the telemedicine device, did it come with the device or did you need to purchase it? If purchased, who was it funded?
Okay, did you hear that?
How was it funded?
Yeah. So first and foremost, I think it's important because this is an open forum. I don't want to endorse any specific product. You can call me and I'll talk to you more directly about what we're using, but I feel that, this is educational more than anything else. So, but our otoscope, when we priced the cart, we priced everything together, a laptop, a stethoscope setup, and an otoscope general exam camera, and then also the cart and telemedicine teleconferencing unit as well. So when we submitted our applications, we included everything in that. So it was about $21,000 per cart.
Okay, anybody else have a question?
Yeah, I have a question. Can you hear me okay?
Yeah, we got you.
Yeah.
I'm Yolanda. Okay, I'm Yolanda Evans over in Seattle. And a question for Dr. Norris. When you were doing the needs assessment, were you able to talk with the kids at all or the youth about their needs and what they were hoping to get out of the access?
Yeah, well, we talked with high school students and we talked with this group of at-risk students at greater length, and we were able to get a sense of what they wanted. And they wanted confidential care, they wanted easy access to care, and they talked about this desire to be treated as an adult, which we see from a lot of, sort of a natural step. And I don't want to be in the, my family doc or my pediatrician's office with all those other 5-year-olds. I would like to be seen and treated as if I'm the patient and the one making the decisions. Does that help? You muted yourself again. I'm sorry.
Yeah, sorry. There are multiple people in the room. Sorry. Yeah,
That's okay.
That helps.
Great.
It definitely helps. Yeah, thanks.
Absolutely.
Okay, we have another texted in question from the streaming audience, Matt.
Okay. This person asked, perhaps I missed this, but from start to implementation, how long did it take to become operational?
It took, 3.5 years. Now, I want to couch that in the fact that we were working with myself as a pretty much volunteer, doing this nights and weekends, and then also with a half-time public health nurse helping with the survey part, and then an HR person who helped with the grants of the implementation and sort of the second phase of getting the project up and running. I think that if we had more investment at the start, we could have done this more quickly, getting through, getting credentialing done and billing done and the other parts. So if you have more capacity, you're going to be more successful. Or a shorter time period, I guess, is a better statement.
All right, I've got one. So you mentioned I'm trying to think back and think. You mentioned one barrier, at least one kind of barrier from a person. That was a local MD, right?
Yeah.
So what sort of issues have you hit from the local school boards or any of the local superintendents or anyone like that? Have you hit those barriers?
So I think first school boards, the school boards have been overall very supportive. There is one former nurse on one of the school boards, and every time that I go and present, she brings up the question and she says, well, Dr. North, what about the abdominal exam? How will you do that through telemedicine? And my response is, you're right, I can't palpate and see if this kid has a ruptured spleen. However, I should be able as a healthcare provider to figure out if this is, Patty's upset stomach before the end of grade test versus she has a hot appendix. And the decision tree, we always have the alternative of calling EMS just like you've had before this network existed. So we are not replacing emergency medical services. We're enhancing access. Yeah. And then a superintendent was sort of opposed to the mental health stuff. I think I'd mentioned that earlier. But his principals, his teachers really see the need, and there's been a change in leadership there in the last month. So we're going to continue to work with the new superintendent. Wow, a big room with lots of people.
Okay, yeah, we've got a question from here at UAMS.
Yeah, I do have a question about how easy is it for the physicians to work these patients into their schedule? Because these are like walk-ins.
Right. And that's one of the
Great
reasons that we decided, and so to repeat the question, what I understood was, how do you work the patients in?
Right.
And what we did was we have created, we're a separate entity. We're not part of a doctor's office. And so the My Healthy Schools project employs a nurse practitioner, and she sees acute kids from the 3 schools on demand. As we're still in sort of startup, right now we're waiting for school to get started again. We haven't gone to really scheduling slots yet, but it'll be done through the nurse practitioner and scheduling as needed. We know that there's going to be an increased demand earlier in the morning where parents are dropping off their kid and saying, well, can Missy stay at school today, or is she sick enough for me to take her to grandma's house before I go to work? In the Rochester model, they do go directly into the primary care offices. They're also using a hybrid of live and store and forward to be able to do that. They guarantee, and I don't know if it's somebody from Rochester's on, but I think their numbers reflect that 80% of the time the child is seen by a provider in their primary care office, but it may not be immediately. And for us, it just works better to use a separate entity and send the information back.
Thank you.
Yeah.
We have another.
Absolutely.
There's another question from the streaming audience.
Okay. This user asked, we have no school nurse in grade school, middle school, or high school. What direction would you suggest we take to be able to accommodate this difference?
That's an interesting question. On a lot of levels. If you're going to invest the money in some sort of a school-based prevention, a school-based health center, where's the best place to start? In North Carolina as a state, we're kind of wrestling with that. Where can you get the most bang for your buck? I think that starting with middle school, where when you're really talking about healthy lifestyles and health education and prevention focus, that's where you'd want to be. In addition, our data said parents who had kids in middle schools were much more interested or more likely to use the service than those in elementary schools. So that would also sort of influence my decision. But you really need to get your local communities, a feel of your local community.
We have another question from here in our room. Go ahead.
All right.
Cultures.
Go ahead and repeat that. I wasn't.
How do you do cultures?
Cultures was the question. How do you do cultures?
Great question. CLIA-waived labs. CLIA-waived labs are, you can have a semi-trained professional, a CNA. We're using the school nurses right now in our pilot network, but we plan to use a trained paraprofessional to do the cultures and then take them to the hospital to be run. So if that's a urine culture or a strep throat. You can also do a rapid strep and record it in the electronic health record, or in Rochester, they're taking the test and showing it on the teleconference, showing the result there. So flu swabs would be the same way. We're not going to be drawing blood at the remote sites. So that is a limitation right now. As far as giving immunizations, that kind of fits into this, I see it as fitting into this realm of questions. We're discussing how to help kids get caught up on their immunizations and are actually involved in a research project with UNC Chapel Hill on using telemedicine around adolescent immunization rates. So, but it would involve sending someone out to the school to give the shot. Yeah.
Any other questions for Dr. North? I know we've got the guys over at Arkansas Children's Hospital on. We're proud to have Seattle, and I don't know the other sites. I'm not looking at my numbers, but I see some other sites. We're happy to have everyone on today.
All right.
I've got another one. Let's see. And you sort of covered this. I mean, what types of IT support do you have right now, and what do you really need over the next year?
Yeah. Well, we have in our grants, we wrote in money for the school system's IT people. So I tried to bring somebody to ATA from the school system, and nobody could get free. But we've got about $10,000 for IT support. We have found that just with the parts themselves and understanding, we're putting in an MCU, we put in a Movi server, that we own. We kind of want somebody here who understands those things. And so Richard Linville is our IT guy, and he's really helping me network with the IT people from the district, and he'll be around to troubleshoot as we expand.